Okay, I'm going to start. Hopefully more people will arrive as we go along. This lecture has the slides in English. If we get more people here who speak French, I can speak in French. We haven't got a translator today, but it's a very important subject that everybody should be worried about. So my name's Elaine Grisdale. I'm the Scientific Director for the SILMO Academy. I'm also the Director of Development for the International Opticians Association. And I'm going to speak to you today about interacting with seniors and dementia, dignity, and the eye care professional. So why should we be interested? Well, first of all, 70% of people who are living with dementia are cared for at home. So it's very likely that they will come into our stores, come into our practices, and need to be looked after. If you work with care homes, 70% of people who are in care homes will have some kind of advanced memory loss, or they are living with the condition. And probably more importantly, you probably know somebody who's living with dementia. Now that could be a family member, it could be a colleague, but it's more likely to be a patient. Now, why is it that I'm talking to you about dementia today? Well, I recently completed a master's in dementia. I'm an optician, but I've got a master's in dementia. I'm one of only a few people who do have a master's in dementia. And the master's program that I chose was one that was from the University of Hull that gave a critical understanding of dementia and an insight into the lived experiences of people who are living with that condition. So for the purpose of this presentation, I'd like you to introduce you to Eileen. This is Eileen about 8 years ago. She's in the south of France, she's on holiday, and she's an ex-school teacher. This is Eileen in hospital 2 weeks before she passed away. You can see that she's feeling pretty isolated. And Eileen was my mum. And I had the privilege of looking after her for the 2 years before she passed away. And so not only do I have qualifications in dementia, I also have a lived experience as well. So what will we discuss today? Well, we're going to look at what is dementia exactly and why should we be interested, because there's an awful lot of misconceptions out there. We're going to have a look at how eye health will influence its progression and how it influences the well-being who are living with the condition. And we're going to look at how we as eye care professionals can be better prepared to serve this population. Because often when people have a diagnosis, they become invisible or forgotten, and actually it's something that we have to look at, not only from a moral standpoint, but also from a commercial standpoint as well. So in fact, this presentation could have been called Improving the Quality of Life of Those People Through Patient-Centered Care. And we know that vision impairments and hearing impairments also, they increase in prevalence with age. So as we get older, we have more eye problems and we have more hearing problems. And these are the most common comorbidity conditions in people who are living with the condition. So if you look at the UK, the statistics are quite worrying. 1 person in 6 over the age of 80 has got dementia. There are 42,000 people under 65 who have dementia. Now, people think of it as an age-related condition. It's not an age-related condition, although people who are older do have it. In the UK, we know that there's about 850,000 people with the disease. It's actually more likely now to be about 900,000, but it's set to rise to over 1 million by next year and to double that figure by 2051. And as I said, 70% of the people in care homes have got dementia or severe memory problems. Worldwide, in 2021, it was estimated that 55 million people had a dementia diagnosis, and that number is predicted to rise to about 135 million by 2051. So it's a health and social issue. Had COVID not hit in 2020, I think this was the next big thing for the World Health Organization. And in fact, even more worrying than these statistics that you have here is that these are the people who have an official diagnosis, but in fact, I think it's quite a lot more than that. So these are the people who officially have the diagnosis, they're on the radar. There's an awful lot more people who don't have an official diagnosis. Now, what's interesting, I said it was a social problem. Dementia doesn't just affect the patient. It affects the people who live with the patient, friends, family, colleagues. And for the 850,000 people with dementia in the UK, there are over 800,000 dementia carers. We said 70% of these people live at home, so it affects the family dynamic. And there's more women than men, and we live in a female-dominated profession, so our colleagues at some time may be affected personally by this condition. So colleagues may be affected. So 35% of all the carers in the UK for all different conditions look after someone with dementia. And what's really, I think, quite sad is that nearly 54% of carers who are aged 85 and over look after somebody with dementia. So what do we know about it? Well, I talked about preconceived ideas before. First of all, because it touches on mental capacity, people think it touches on madness and sadness and not being quite right. That's wrong, obviously. We look at some of the inflammatory language that's out there. This is some language that you can see there that uses kind of epidemic-type language. So when you're looking at things in the media, they'll say that it's a dementia disaster, a tsunami, a silent epidemic, rising tide. So it's really quite catastrophic language that's associated with the condition. Deadly, kills slowly, strikes victims, claims lives. And in fact, without going down this very sort of dramatic language, when you have a dementia diagnosis, the dementia is not going to go away. It's something that's going to progress. It's something that you will die with, but you won't necessarily die of. So it's not something that there is a cure for, but there's ways we can make it better and give hope to people. For the people who work in the charities, it's quite hard because cancer you can survive and you can bring out the person who's got cancer and you can say, here's a survivor, give me money for research. But in fact, with dementia, you don't have that. You don't get better from dementia. So it's quite difficult for the people who work for Alzheimer's research, etc., to get funding because there's no success stories. And they need support. And all of these things and the miscommunication means that it's the most feared medical condition of people who are aged over 40. So it's even now more feared than cancer, more feared than heart disease. So some common thoughts that are out there is that it's a sad condition where you lose your memory. It turns elderly people into vacant shells, or in one paper we've seen there's an awful lot of people who use the word zombie. It's a disease where you totally lose ability and capacity. Full-time care is needed and there's no more communication. But the reality is, the two photos you see at the top there of people who look like patients who would come in for a pair of bifocals or progressives is more likely to be the scenario that you see. It's not somebody who is gazing into the distance, not knowing what's going on, which is a common misconception. And if you look at the data there, this was from a study that was done in Canada by the Alzheimer's research there, and we asked people living with dementia or caregivers who were responding on behalf to their question, how would you rate your quality of life? In fact, quite a few said excellent, very good, good. Then it got down to fair and poor, but it's more people who say good or I'm coping than people who are saying I can't cope and I'm absolutely devastated and I can't function anymore. If you want an interesting paper to read, the reference is there from Susan Bayernick in 2011, and that will take you into the way language affects how we think about the condition as a society. So dementia is a generic term for different brain disorders that trigger a loss of brain function. The most prevalent type of dementia that we know is Alzheimer's disease. 62% of all dementias are Alzheimer's. And then that's followed by vascular dementia and mixed dementia. Now, Alzheimer's is when there are a buildup of proteins in the brain and they get tangled up and they stop the different nerve impulses getting through. And we can't break down those proteins at the moment. Vascular dementia is more caused by lifestyle, so it's from a lack of oxygen to the brain. So if you've been smoking all your life, you are at high risk of getting vascular dementia. If you have a stroke, you're at a risk of having vascular dementia. If you're in some sort of accident, you might be at a risk of having vascular dementia if your brain is starved of oxygen. And as I said before, dementia is a terminal condition. Now, the little picture that you see there, that photo, comes from UCL in London. And it's a special type of imaging that has been taking place. And you can see that the traces in red, those traces are loss of brain tissue from one appointment to another within a 2-year span. So the back of the brain is responsible for vision. The parietal lobe, the occipital cortex, where it tells us where things are in space. People with a condition called posterior cortical atrophy, we'll talk about that in a minute, have more shrinkage at the back of their brain, and this is the type of Alzheimer's disease that affects vision. It's often known as visual dementia. And memory goes in dementia, but not always. So memory is not always the first thing, which is an indicator that somebody might have dementia. So the front of the brain could be affected, and this is where we have our behavior and our social skills, and the memory can be okay for some time. But you get some people who say, my husband's not the same. His personality's changed. So someone who could have been very sort of meek and mild becomes aggressive, or somebody who was quite aggressive might turn the other way and become meek and mild, and you don't really recognize the person who you've been living with for the past 30 years. And that would be an indicator of somebody who's got some kind of brain disorder, which might be some sort of dementia. There are over 100 different types of dementia, in fact. And dementia affects every single person differently. You can't say that everybody reacts in the same way at all, which is why person-centered care is so important. So there's a quick way of remembering what the symptoms are of dementia, or possible symptoms are of dementia. They're the 5 A's of dementia. Now, the first one is amnesia. That's memory loss. And if you think of all your memories on a bookshelf, and you put your most recent memories on the top shelf, if you tip that bookshelf over, the first memories to go are the ones at the top. So all your recent memories will fall away, and you're left with memories from a long time ago. And so one of the strategies for engaging with people with dementia is to take them back. Take them back with music, take them back with photographs, reminiscence therapy, really. And you can communicate with them in that way for people who have very bad dementia. Aphasia is how they knew that Bruce Willis had dementia. He was diagnosed with aphasia. And aphasia is a problem with speech. It's a problem with speaking, or it's a problem with understanding speech. And so you might not use the right word. You might explain something without using a word because you can't remember a word. Or you might say something totally the wrong way and sort of come out with gobbledygook, a language that you don't really understand. And if you're a professional, it's your job to try and be understood when you're talking to somebody. So you might have to modify your language because they don't understand properly what you're saying. Apraxia is when you've done something for a long time and you know how to do it. It's automatic. So if you were tying your shoelaces, you know how to do that. But you might forget how to do that one day. And things that you've done automatically for all your life might suddenly not become automatic anymore. And that might add to agitation because you're frustrated that you can't remember how to tie your shoelace. Agnosia is really in the, not final stages, but sort of when it's well developed, you might have agnosia, and that's not recognizing people, places, or things. So it's not recognizing something. Now, what I have to say is I've done a lot of CPD with optometrists, opticians, ophthalmologists over the time, and we sometimes sit in groups and we analyze prescriptions. And you're all talking about the analysis of this prescription, but when I throw in, this person has a dementia diagnosis, everybody kind of freezes and says, oh, we've got to talk to their carer. And actually, no, you don't, because about 80% of the people who have dementia have got capacity. They know how to interact, and you have to give them that dignity, and it's their right to be able to take their healthcare into their own hands. So think of a diagnosis of dementia as a long line, and from the day you get it, you don't suddenly change as a person. Society does change you, because the way society thinks that person's got dementia, you change towards the person, and that makes them vulnerable. So first of all, there's shock and confusion when you get a diagnosis like that, and you think, gosh, maybe it's game over, what's going to happen? And the risk is, as I said, that they're defined by their condition and they tend to lose their identity, but that's our fault. It's not their fault. And we have the chance to give people the chance to live well with the condition and look out for the positives. We have a chance as a profession to give these people hope. So, key role to play: good vision, good hearing, good connection, stay independent for longer. I'm not just saying this, I have research to back it up. So here we go. So, one of the key studies in the UK is something called the PROVIDE study, which was done by Mike Bowen and his team in 2016. And they sampled a range of people who had dementia who were aged between 60 and 89. Of those who had dementia and a visual impairment, 32.5% of them had a VA that was worse than 612, and 16% had a binocular VA worse than 618. So they're walking around with not great vision. 16% of those people couldn't read standard newspaper print with their current spectacles, and almost 2/3 of them could use it after a dementia-friendly sight test. 22% said they'd had a sight test within the last 2 years. 19% said they hadn't had one for over a decade. That might be a memory issue. But the College of Optometrists said that the findings emphasize the need for optometrists, and if you're in France, ophthalmologists, to allow more time when you examine the people, because they don't like stress and they don't like having to make a decision quickly. So you need more time to do an eye examination on a person who has dementia. One of the things that they said was, we don't always know before the person comes in that they have dementia, which might mean we need 2 appointments and we're not paid for that. And that's a problem. So how can we improve a patient's life? Well, by recognizing the symptoms early on. People with dementia often have impaired visual spatial skills, and executive dysfunction tends to come quite early on, compared with language and things like that, behavioural issues that often manifest a little bit later. But we need to have active management, certainly of refractive error. Dry eye issues, that's often a big thing. That can impair vision. Cataract, certainly. So if cataract is found, they need to be fast-tracked for cataract surgery, and binocular vision problems. And if you have a website and if you communicate with people, you need to indicate to people that clumsiness might indicate a vision problem. People who have dementia don't often know that they have a visual problem. They think it's part of the condition. It might be part of the condition, but it still needs addressing. And so clumsiness, not being able to find anything, memory, being isolated, not wanting to engage with people, not wanting to do things, and not being able to see even if they've got the correct glasses. And that also is a problem, because they might come into you, they've had an eye examination, you've made up the spectacles, and you can't find anything wrong. You might want to hazard a guess at changing the lenses, sending them back to see if the lenses are okay. But actually, what we forget is that we see with our brain and not with our eyes. And if they do have a dementia diagnosis, or even if we don't, and we have to pick that up, then there could be a problem with their vision. We have to remember as well that an awful lot of people live alone. They live alone, they don't see a lot of people regularly. We might be one of the only healthcare professions that they see. They might be regular patients of ours, and we have to look out for signs that there may be a problem, because there might not be anybody else who can flag that up. So in my research looked at how does eye health influence the progression of dementia and the well-being of people who have the condition. And 4 main themes came out of that research. One was cognitive decline and the impact of poor vision. The second, the importance of a good eye examination and adapted clinical tests. Identification of what dementia-related visual problems look like, and how we can improve the quality of life for patients with the correct spectacles. I said before that there's an awful lot of research which is out there now, relating vision and correcting vision to improving quality of life for people. It's my concern, because I've seen it personally, that when you take a person with dementia into an optometrist or an optician's, 1, they don't have enough time, 2, sometimes they're flustered, and 3, not every time do they get the spectacles that they need. There could be coercion from a carer or somebody who doesn't know them very well, saying no, they don't need new glasses. Or because they've got the condition, they're not going to benefit from new glasses because they've got a condition that they're going to potentially die with in the next 3, 7, 10 years. But what you have to know is that during that time, you can make such a difference and make them independent for longer, and potentially slow down the condition. So in 2010, they were saying that visual anomalies go untreated, it could adversely affect cognitive function. Poor vision's associated with dementia. Littlejohn et al. In 2022 said that there's an increased risk of dementia if someone has impaired vision. Now, it's been officially listed by the Lancet Commission now that untreated refractive error is now a modifiable risk factor for dementia. You saw the statistics at the beginning of this presentation, and you can see that it's growing. It's a growing problem, and we have a role to play in slowing down the rate of people who are going to have dementia. So there's a higher incidence, as I said, in older people as well who had poor visual acuity. Colour vision deficits were identified as being present in some patients. All types of visual impairment have been associated with higher prevalence of dementia. And we don't know about it. We're not talking to patients about it. We're not saying come in for an eye exam every year. the healthcare professions are not saying, as soon as you have that diagnosis, go and have an eye examination, and then you're on the radar of the eye care professional. But that's what it should be. Now, you can either have dementia and sensory impairment separately or together, but a patient with dementia can't always realise that they have or are developing a sensory impairment, and somebody with a sensory impairment can't always tell you that they've got dementia, or they think they've got the onset of dementia. So there's a little bit of unravelling as a healthcare professional to avoid masking, to see what the actual problems are. You have to be somewhat of a detective. We know that between 20 and 50% of visual impairment is correctable, but remains undetectable in older patients. That is a huge percentage. We know that older patients are predisposed to dementia, and visual impairment of all types was found to be 3.3 times more common in residents in care homes. So there are people in care homes who are being looked after by people, and their vision is not being addressed. They may be wearing the wrong glasses, they may have lost their glasses, but they're not being seen by an eye care professional. Cataract has also been associated with social isolation and decreased cognitive stimulation, but the College of Ophthalmologists in the UK have written guidelines to have people with dementia assessed for cataract, but also operated on early. And cataract extraction can reduce cognitive decline and the risk of dementia. And often the people who are caring for people with dementia say, I don't want to put them through an operation. I don't want them to have an operation. It's going to be too stressful. It would actually help them a lot. And if they have capacity and the surgeon is well versed in communicating with a person with dementia, it can be a revelation to them and help them enormously. So one of the tests we can do in practice to see if we have a suspicion that somebody has dementia is something called the clock face test. And you get this is used a lot in by memory clinics when they're assessing people, but there's no reason why we shouldn't be doing something similar. And this detects visual spatial difficulties, and depending on how the clock is copied. So you ask a person to draw a clock face, and you say, put the time at 2:30. And you see whether the numbers are in the clock, they're in the right order, whether the hands of the clock are pointing to the right things. And it actually will show you the degree of dementia, how bad the deficit might be, and what the interventions might be appropriate. Other simple tests that can be done, one is pupillometry. So if you give somebody who has dementia a memory task to do, so remember these numbers, and you give it to somebody who doesn't have a dementia diagnosis, the person with dementia will stress and their pupils will open. I would invite you to find a film on YouTube, which is from Dr. Marianne Coleman, who is in Australia. And she's a great advocate for vision correction and dementia. And it's called What's Dementia Got to Do with My Eyesight? And she will take you through some of the optometric tests that you can do and the communication you can have with this patient population. So as I said, posterior cortical atrophy is known as visual dementia. Any paper that's written by Sebastian Crutch and his team at UCL is worth reading. And this leads to its dysfunction, its atrophy, as I said, at the back of the brain, and it's going to lead to a progressive deterioration of vision in patients who have the condition. It's more likely to be women who have posterior cortical atrophy. They're going to be more likely between 56 and 65 years of age when onset is happening. They will have space and perception problems. They might have problems with numeracy, with literacy, and praxic skills. Praxic skills are things that you do every day, like I said, tying shoelaces, stepping off steps, that kind of thing. There are other dementias that will mess with vision, like Lewy body dementia, and that's where you get hallucinations. And if you want the uniform definition of that, look at a paper by Crutch and his team at 2017. So what do dementia-related visual problems look like practically? They often complain of reading. A lot of people like to read. They can't read anymore, can't look at their phone, that kind of thing. They have problems with visual perception. So it could be that they have a coloured carpet. They have a carpet with many patterns on it, or they have curtains with patterns, or if I stand in front of them with this blouse on, that would disturb them. There's too much going on, and it disturbs their brain function. If somebody feels wobbly in that case, then it could risk, they risk falling, that kind of thing, and being disorientated. Visual hallucinations, as I mentioned, visual agnosia, not recognizing things, or knowing that there's a cup there, you can see the cup, but when you go to touch the cup, it's not there. So you've put your hand there, but the cup's over there. Disruption in the visual field, misidentification of objects, as I said, patterns on carpets or clothes. And that's similar to people, the reaction you'll get is similar to people who have autism. Sometimes if you're dealing with people with autism, they don't like busyness. They don't like busy patterns or colours and things like that. That disturbs them. So when you don't know what's wrong, I can't read in my spectacles, you've checked the spectacles, you've checked the health of the eyes, you've checked the prescription, then it's a chance to send them to neuro-ophthalmology. And then it's all about coping strategies. This is interesting. This is an artist called William Uttermollen, who was based in London. He was an American artist. And he painted himself in 1967. In 1996, he was diagnosed with dementia. And he painted himself every year after that. And you can see how his perception of himself changed as his condition progressed. I'm not showing you this film now because we haven't got time. Please do check out this film. If there's anything you go away with today, it's this. Look at this film, and it's people who have posterior cortical atrophy talking about their symptoms, and actually the film tries to simulate their symptoms, and there are things like glare, missing objects, not being able to go downstairs, that kind of thing. But what I want you to know is to listen to their voices and hear how lucid and they've got consent, intelligent. They're not people who are sitting in a chair staring out into space not knowing what's going on. These are many of our patients who come into us, and you don't necessarily know that they have dementia. One of the quality of life things that we need to preserve is how to get around, how to move around and getting around without falling. And the great Professor David Elliott, who's been here for the last 2 days speaking about something else, is a leading light in vision and falls. And he says that falls are predictable, they're not accidental, they can be prevented. And that's good, because falls were contribute to morbidity and mortality in dementia. And people with dementia are found to have 8 times more falls than control groups. So we need to ensure that they have good vision so they don't fall. Good vision, good hearing. Vision and hearing play an important part in being balanced and trying to recognize hazards. So I talked about falling being a risk. There are multifactorial risk factors. Some of them you see there, but vision impairment is one we've seen, spatial awareness, and tripping hazards. Now that carpet at the top, by somebody who had posterior cortical atrophy, would be seen as being like a hole or a bit of a moat. So the person would try and avoid it. They'd think they were going to fall in. And that swirly carpet would destabilise them, and that would make them want to fall. Now that's my mum. That was her living independently with her dementia in 2016. You can see she's got everything around her that she wants. She's eating on her knee, she's got her remote control, she's got 2 pairs of glasses, she's got her dementia guide on the fireplace. She has everything around her that she needs. My mother fell and she broke her hip. And that really, she had lung cancer as well, she had dementia. She could talk and she could live independently. When she broke her hip, she couldn't live at home anymore, and she had to come and live with me for the last 2 years of her life. And that you see over there is her in a hospital bed in what used to be my dining room, and that's what happened to her because she fell. Glasses can be a risk factor if they're not fitted correctly and if they're not adapted correctly to the person. And with multifocals, you're twice as more likely to fall than with single vision lenses. You have to be aware of the swim effect in these lenses and the magnification. So 2 pairs are often better than a pair of varifocals when someone has a dementia diagnosis. A lot of people who are older drive. And one of the first warning signs, and one of the warning signs for us with Mum, was that she had scratches all on the side of her car and the wing mirror that was knocked off because she kept hitting the gate post when she drove into the house. And also we had people after she died from church who said, "Oh, your mum was very kind. She used to offer us a lift home from church, but we used to pretend we didn't need one because she drove very fast." And my mum was really conservative and would never drive fast, but apparently her condition made her do that. So we need frequent checkups. It is kind of taking independence away from them a little bit, but they have to stay safe. And there's an awful lot of research on this as well that you can access. One of the worst things I think about not being able to function anymore is not being able to enjoy your hobbies and pastimes, especially if you live alone. And these are the things that keep you engaged for longer. So if you don't have good vision, you can't continue to do the things that you've loved for a long time. So seeing clearly can help them to enjoy pastimes and improve outcomes. And there's research to show that. Just dealing with patients who are coming in quite quickly. Please be aware that anybody coming into town for an appointment, that can be anxiety inducing. My mother used to prepare for about days before. She'd leave herself little notes. And on the day itself, it took us about 3 or 4 hours to get out before we got to the appointment. When they get to the appointment, everything is heightened. Noises, lighting, things can fuel their agitation. So you need to reduce noises if there's background noise, or you need to be able to take the patient to a quiet area in the practice. And this is why it's useful to know before the patient comes in whether they have a problem or not, and to give them more time, and to calm them down and to settle them. There's a very good film called, and I'll think of it before the end of the talk, made by St. Thomas's Hospital, about a lady going for an appointment. I can't remember what it's called now. Yeah. Barbara's Story. If you look at Barbara's Story on YouTube, there's a 12-minute film and one that's a lot longer. Watch the 12-minute film, and it shows you what this lady going for an appointment in hospital is feeling, and how people think they're doing their job and being very polite, but actually they're not helping the person who obviously needs help. Judgment can be impaired. One of the red flags is that they have a difficulty handling money or numbers. So if somebody comes into you and normally they only buy 1 pair of glasses and suddenly they want 3 pairs in 3 different colours, be wary and say, let's try one for the moment and see how we go on. And then we'll look at making the other ones for you. They have impairment with judgment. When we cleared Mum's house out when she died, she had about 6 different cardigans, all of the same style, all in packets, all in different colours. She just bought things. So this is one of the things that could identify that there's a problem. They might not be able to finish tasks. Too much choice is overwhelming and confusing. What you wouldn't do with a patient with dementia is take them over to a frame bar and show them all your range of frames and say, let's try on frames, what do you fancy? Actually, what you would do is you would sit down and you would say, okay, well, do you like plastic frames or metal frames, and show them what plastic and metal are, and then try and assess what the size of their face is to assess the size, but then try and find a colour that they like, and you might need to show them the colours, and you go away and pick no more than 3 and bring them back. You can go away again later, but no more than 3. It will confuse them and it might lead to agitation. It's even worse in the eye examination room because they're in the dark, the lights are on and off, and you are asking them to make decisions quickly. Red or green, 1 or 2, better or worse. That's stressful for a person who has dementia. Even if they've got capacity and can talk to you like I'm talking to you now, having to make decisions like that quickly is stressful. So that's why you need more time and you need to be more gentle in your approach. You have to build trust. You need to tell them what you are doing and why you are doing it, and tell them who you are. Remind them who you are and what you're doing. If the patient comes in with a carer or a family member, often the temptation is to talk to the carer because it's quicker. You know the person, I'll ask you the questions. No, that's depriving the person who is disabled, because dementia is a disability, of their dignity. It might be hard work, it might take time, you might have to repeat yourself, you might have to rephrase what you're saying, but you have to give them the dignity to reply. Also, when you're going to get frames, don't walk away with them and talk at the same time. Be facing the person who you're talking to so that they understand what you're saying, and to ease them into the conversation. Capacity to consent is vital. It must be established, and there are studies to show, as I say, that people with dementia, a lot of them can give consent. And having dementia, as I said, still allows that person to make decisions on their own. It's not for the carer to make decisions. It's not for the eye care professional to make decisions. It's for the patient to make decisions. And actually, capacity can change from one day to another. So it could be on one day they don't have capacity, but the next day they might, or the day that they're with you they have capacity, so you have to respect that, and then you go ahead and do what you have to do. You have to be aware also that I said that a lot of people are cared for at home, and there can be tension in relationships, tension in families because of the pressure of this condition. And so you have to be aware of maybe the dynamics of when people are coming in, and be aware of any possible coercion. Or the fact that if the person orders a pair of spectacles, if 2 days later their family ring to cancel that order, it's not for the family to cancel the order if the patient had capacity. The person must do it. So you have to be aware of this complicated communication between 3 people going on. One of the things that happens when you have dementia is that you misplace things. So you can see the bottle of the keys in the fridge there. Often they misplace their glasses. It could be just that they're a bit forgetful. So if any of you have put the keys in the fridge or anything like that, don't worry. It could just be simple memory loss. They might not be able to retrace their steps to find things. One of the things is they're suspicious of people hiding or stealing their belongings. So my mum would get very upset if somebody moved her bag or her walking stick. Now, if you are taking measurements and there are bags around your feet and you just go to move them, that could incite agitation in the person. You have to say, would you mind if I moved your things? Don't just go and push them out of the way or move them to take a measurement or put drops in or whatever. Think about spare pairs of glasses because they might lose them. Think about glasses chains. Think about brightly coloured cases where they can find them easily. All of these things can help. They have time and place mix-ups as well. So it could be that they come in for an appointment and it's not the right day. Now, if you remember what I said before about the stress that's induced about trying to get to an appointment, if they come in for an appointment and it's not the right day or not the right time, please try to accommodate them. Even if it's just to spend 5 minutes to check something, how they're doing, and then make another appointment, please see them. Don't reprimand them and say, you got the wrong day, come in on the right day. Many dementia patients will wander aimlessly, they'll walk off and they'll get lost. This could happen in your waiting room. So, for instance, if they want to go to the toilet, take them there, wait for them, and then bring them back. Or, because they mix up time, if they've been waiting 5 minutes or even 10 minutes, they could get agitated because they think you've forgotten them. They're worried that you'll forget them. They might think that they've been there a lot longer. So, again, be mindful of that. Put them at their ease and make sure they're okay. They repeat themselves. Now, when you're a carer, this can drive you crackers. It's quite wearing, but you have to pretend that it's the first time you've heard it. Don't shut them down and say, you said that to me already. If they're saying it a lot and not with sort of changing the subject, you've been able to sort of deflect the situation or get through to them, then do sort of try and find another topic. Try and get onto a different topic. I talked about problems with vision and spatial awareness. They also have problems, like low vision patients have problems, and things like contrast. So what you wouldn't do is serve them fish, white fish, on a white plate. They won't be able to distinguish that there is a white fish and mashed potato on a white plate. So in that case, they wouldn't eat. And they forget to eat. They forget to eat and they forget to drink. And forgetting to drink means that they're dehydrated, and that also can play on their memory loss and the fact that they are sort of feeling well in themselves to be able to interact with you. So a lot of the coping strategies that you have for low vision patients, you can use with dementia patients, and advice that you give. We know it's a lonely and an isolating disease. It's especially lonely and isolating if you can't see and if you can't hear. It leads to depression, and that depression leads to the fact that that dementia will get worse quicker than it normally would. So you can improve the quality of life for that person with the correct glasses and the correct hearing. A little anecdote. When my mum was in hospital, you see her there, in the last 2 weeks of her life, she didn't want any TV. She couldn't watch the TV. It was confusing. She couldn't read a newspaper. She couldn't do her crosswords anymore because she felt that the letters were jumbling like they do with dyslexia. I bought her a newspaper every day. Why did I buy her a newspaper every day? Because she had always had a newspaper every day, all of her life, and it was a comfort to her. It was a bridge to home. It was a bridge to the past. She wasn't going to read it, but it was there. So you have to be able to, as I said, keep the dignity of the patients and make them feel safe. And that having a newspaper on her hospital bed every day was a comfort to her. She was never going to read it. She couldn't read it. So we can encourage the patient's entourage, the carers, to do things that they should be doing and to make them correct person's vision. They will get forgotten if we do not do something, and we can make a difference. Another thing that's associated with dementia is loss of motor skills. It's not just due to arthritis or aging, it's due to what's going on in the brain. So ask how they're coping with that, how they're coping with fastening buttons, changing hearing aid batteries, putting eye drops in, opening a glasses case, that kind of thing. You can help them. You can give them a better glasses case. You can help them with maybe a different system to put eye drops in. And what would be really nice, especially if they live alone, is that you offer to change their hearing aid batteries for them. Would you like any help? I said that we know our patients better than anybody else. It could be that Mrs. Jones last year looked really, really nice. She always came in a suit and she was really nicely dressed. This year she's come in, she's looking a bit grubby. She might not smell very well. One of the things that goes when you have dementia is your hygiene and your grooming. Again, if she's not got an official dementia diagnosis, this might be a red flag. I said they forget to eat and drink. It might be nice when you're having your consultation to offer them a glass of water or a cup of tea. That might be something that's good. And again, we don't want them dehydrated. Nutrition advice should be on your websites, so to make sure they've got healthy brain health. And you can see all the good things there. Dark chocolate's one of those, that's good. Could be with the agitation or other things that they make inappropriate comments to you or your staff. Dementia means that sometimes they don't have a filter. They're not doing it on purpose. You just have to, just let it wash over you. Don't let it affect you. They might think that the glasses are theirs. They won't think that for long, so don't try and sort of snatch them back. It's a bit like having children in the practice sometimes. Let them have them, but then sort of try and take them back afterwards. Be kind. They only are verbally or physically aggressive if they feel threatened or if they don't know what's going on. So that's why I said before, you have to explain what you're doing and why you're doing it. And having a sign around your neck which tells them visually who you are and what you're doing is very important. So you've told them, the chances are they might forget in 5 minutes where they are and why and who you are. So having that round your neck is a reminder. There's always a reason for them getting upset or agitated. So as I said, if someone tried to take my mum's walking stick, she'd be very, firm that she wanted it back. Lastly, very quickly, how are we going to improve the optician experience for people? Recognize that correlation between visual impairment and dementia. It's very important. Remedy any impairment. Manage that refractive error and any ocular pathology. It's not too late for cataract surgery. It's not too late for new spectacles. You have to understand the visual disturbances that are linked to dementia. You have to determine if that decrease in visual function is caused by poor vision on its own or whether the dementia is the cause. So you need to make that distinction between the two. Please do not rely on preconceived ideas of dementia. Look into this and find out what you can do and how you can make a difference. And self-reported visual impairment by patients with dementia is very rare. So you're going to have to find out that they have an impairment. Positive strategies, 3 C's, clean glasses, current glasses, correct glasses for all spectacle wearers. Look for signs of depression or falls or both. Make sure they have a yearly eye exam because that's not always recommended. Look out for cataract. They need to be fast-tracked. If you can fast-track them, that's great. And we need to make a difference there. That's the cataract surgery in patients living with dementia. That's a paper written by the College of Ophthalmologists in the UK, and again, that's very much worth a read. So, not a natural part of aging. It's caused by diseases of the brain. It is possible to live well with dementia. We have a role to play in that. It's not just about losing your memory, and there is more to the person than the dementia. Person-centered eye care. That's what we have to strive for. That was us in happier times, but she did have a dementia diagnosis there, and she was living in her own house. And if you need any more information, that's me. Thank you very much for your attention.